The leaflet of a big atrium, Michael, always has to be appropriately sized and shaped in everything, and in construction as well, and certainly so when we do mitral valve repair. And Cardinal is a project that we can fine-tune an angioplasty system with to the patient's very specific anatomical and pathological requirements as far as saddle, shape, stiffness, and size are concerned. Do we want to keep all these rings on the shelf to have a fit in every patient? I think a hospital is going to kill us. And let's briefly go through the functional approach, which is the basis of every mitral valve repair. Type 1, ring enlargement of the native annulus. Type 2, excessive leaflet motion, prolapse of either anterior or posterior. Type 3, tethering. What a mitral valve surgeon wants, he wants one thing. And I always say to my young trainees, keep in your head, you want one thing at the end of surgery. This is this, far away from the outflow tract, early closure, good surface of coaptation, and you'll be okay. But it's a dogmatic theory, and what does it mean in practice, reality? We all know there's a etiology that causes lesions, and the lesions will cause the dysfunction. So peroperative analysis is still very, very important to know whether there is excessive tissue, etc. If we talk about type 1, what we want to do with the ring, what we first want to do is actually create a sort of hanger in between the trigones that becomes rigid, that prevents this distance from being smaller after the angioplasty, and only then we want to create a lesser distance between septal and lateral anatomy to obtain this. In type 2, we first want to correct prolapse, but we deal with all sorts of lesions, and especially, I don't like the term Barlow anymore, and in my database now, we just quote no excessive tissue, excess grade 1, limited to P2, excess grade 2, limited to posterior leaflet, excess grade 2, the full-blown Barlow, like we used to call it earlier. And with the Barlow, we always have to keep in mind that at the end of the procedure, you may keep too much tissue and height in the posterior leaflet that'll push up the coaptation surface towards the outflow tract, and if then there is redundant tissue in the anterior leaflet, it's got one way to go, that is to say into the outflow tract, causing gradient and causing mitral valve insufficiency. Again, that's not what we want. What we want to do is actually appropriate coaptation. Third type, type 3, tethered leaflets, no prolapse, limited motion, which keeps the leaflet in the ventricle. What we want to do, we want to downsize to make sure we have enough surface of coaptation. And Robert Dion, he's proven, he's got the evidence, you need 12 millimeters of coaptation to enhance reverse remodeling. Let's have a look what we want to obtain. Cardinal, we can obtain a shape that is adjustable. We can obtain stiffness that is adjustable. We can obtain a saddle is adjustable. Not all patients have the same saddle. Look at the patient right inside, almost no saddle. Left inside, very pronounced saddle. And last but not least, we want to adjust the size. How's that going to work? Let's see how that is going to work. And I just hope this is going to play. And I hope there's going to be sound as well. Fingers crossed. After perfect positioning of the left atrial retractor, and the arch that this keeps the venting out of the way, we can have a perfect look of the mitral valve. And obviously here, we're dealing with a mitral valve without any prolapse. It is a type 1, and it is a valve with a small anterior leaflet. If we look at the height of the anterior leaflet, on echo, it was just a little over 22 millimeter, a pretty small anterior leaflet. So obviously, in this patient, where there is septal hypertrophy, if we're going to make the anterolateral diameter smaller, there is going to be risk of SAM. And in this patient, sizing is absolutely critical. So we're very, very happy to have an adjustable ring where we can, after weaning off bypass, look at the coaptation surface, look at the behavior of the anterior leaflet to make sure we have the ideal size. It is so obvious that some patients have a huge saddle shape and huge bulging of the aortic aortic curtain into the left atrium, and some patients have a pretty flat saddle shape. So all stitches are in place. We want to have a perfect view of the valve. That is to say, I want my camera to be perpendicular to the plane of the valve. And at this moment, this is the appropriate moment to do the sizing. To have perfect adjustment, I'm going to try to pull up the anterior leaflet at its mid portion. That is to say, at the level of A2. And if I do so, this is it. Then we'll see that this 26 sizer perfectly covers the anterior leaflet. So the tip of the ring is going to be put in the middle of the base of the anterior leaflet, right there, which is done. Barak, you can hold it. Now we're going to turn clockwise this knob until we feel resistance. I do not feel any resistance yet, and at a certain moment when I feel resistance, which is the case, I come back half a turn, and now I'm going to engage by pushing this knob in. Now we put the sizer and the sizer handle into the prosthesis, and I'm going to turn the adjustment dial from 1 to 2 to 3. I can count these. I can easily see these figures right in the window right there. And the ring is perfectly adjusted to the sizer we have when we are at number 5. We're going to wet our prosthesis a bit for it to slide easier. And we're going to introduce it. There we go. All right. Right? We add saline, and this is the first test we do, and obviously on this very first test we have a very nice coaptation already. We're just off pump. We have a systolic pressure of 71/37. We have good coaptation, and I'll have my anesthesiologist judge what the length of the coaptation is right now. There's no leak at all anymore, but I think on morphology we see a coaptation surface of...
Well, I just measured, it was 3.5 millimeters.
And now I'm going to go to level 5, and what we see at level 5, we should see that the AP diameter is smaller and the coaptation surface bigger. What do you see right now, Patrick?
I saw the angulus effectively getting smaller, and my coaptation, let me correctly measure it here, is now at 5 millimeters of length.
It's 5 millimeters. We go all the way to level 6 in rotations, which mean we even adjust more septolateral diameter, and we see a coaptation surface that just keeps on increasing. So this is the appropriate moment where we're going to get into the disengagement procedure, because the cord that I can adjust the ring with is still attached to the ring, and now I have to disengage. This is the dial to adjust. This is the knob that we're going to disengage with. You see the two black knobs here. When I press them, the knob is going to come loose. Comes out of the tool. What we're going to do now is turn clockwise, and the more I turn clockwise, at a certain moment it's going to be loose completely. You see on echo that the cord is still attached to the mid portion of the base of the ring, and we're going to see the detachment in a second. At this moment, I think I can already come loose, which is the case, and I can bring it. We move to the next case, which is type 2, with prolapse of P3 and anterior leaf. We're going to move a bit further. You're going to see this is preoperative echo,
3D image.
3D image. Compress the AP diameter endoscopic image. Otherwise, we're going to see the problem. We're about to size. An adjustable ring in terms of. By the way, my average size of a mitral valve ring is 34, to be not 28, to freeze because most of these patients are degenerative patients. This type 2 case with excessive leaflet motion at the level of A2 and A3, I did 2 double Gore-Tex cords that go to A2, A3, and I did a triangular section at the level of P3. The estimate, as far as sizing is 34. We move so that for good to look at echo and to look at the adjustment dial, which is the most important 7-8 thing right here. So we adjust, we go from 1 to 2 and to 3, and progressively on echo, it is pretty obvious that the septolateral diameter of the valve is becoming smaller, and the height of the surface of coaptation is becoming bigger and bigger. We are going to go all the way to 4, and at this point, I'll ask my anesthesiologist to measure again, to stop the cycle and measure, and we're probably going to have something like 6 at this very moment.
6.6.
We've been able to go to 8 in this patient. In each and every type 3 patients, with this device, you do not downsize the intertrigonal distance. What you do, you downsize septolateral. And we've been able in every single patient to go to 12 millimeters. I think this is really the device of the future. Cardinal is something extremely special, isn't it, Francesco? Thank you.